Today is Saturday, August 24th, 2019, and welcome to my PCD life. I'm back home after 2.5 great days at the PCD Foundation conference. Sorry for the background noise. It was a great conference. So there was a lot of research that they talked about. Now, one of the problems with the research is a lot of this is new and it hasn't been published yet. So, I can't really give any details, but as soon as more of this research gets published, we'll certainly make sure that you guys hear about it, either through links on the Facebook post or maybe through videos. So I have two interviews. One was with an ENT who spoke about the sinus issues with PCD patients. And I just think it's really neat that they're starting to do more research in the sinus and ear issues that we PCDers develop. And then the other piece, I talked to another doctor, and I talked with him at ATS, but he was here from Germany talking about the genetics. And so it's just really interesting to me how with the genetics, they're finding out there's now 43 genes and still more to be found. And they're finding out that each gene can produce different symptoms or issues for patients. So, it's the more we find, out, the more questions that seem to come up. So hopefully you'll enjoy these two interviews. I'm here with Adam Kimple. He's one of the speakers, spoke yesterday. He's an ENT, otolaryngologist, which can be a mouthful for some of us. And he's with the PCD team in UNC. So can you tell us, as PCD patients, the importance of being seen by an ENT on a regular basis?
Yeah. So I know people with PCD frequently have a lot of clinic appointments with their pulmonologists, and those are obviously very critical. But I do think it's very important to kind of maintain a relationship and at least intermittently, probably once a year, see a ENT or an otolaryngologist to make sure that the ears are healthy and the hearing isn't decreasing, as well as patients frequently have had sinus surgery, and I think in reality, a little bit of monitoring should be done in the sinus cavity to make sure that you don't develop any problems after surgery, things like mucoceles. And an ENT with a nasal endoscopy, the camera in the nose, can kind of make sure that things are healthy and safe within the nose, especially after surgery has been completed.
Now, one of the things I found interesting from your talk yesterday, so I'm one of those people who does not have a sense of smell. Mm-hmm. And so when you talked about people, those of us that don't can typically smell gas,
yeah,
which I've never have, but definitely ammonia.
Yes.
And so your explanation for why we think we smell it.
Yeah. So smell or olfaction essentially happens through a series of nerves that kind of come underneath the brain and then drop into the nose. It's called the olfactory nerve. And that's how true smell is essentially transduced to the brain. And there's thousands of different receptors for all the different odors that we perceive. And in people with chronic sinus disease in general, not just patients with PCD, the odors can be blocked in their ability to actually get up to the component of the nose that's very high and kind of central. And so you can have a loss of the sense of smell because the odors can't get there. But after time with inflammation, you can actually lose the nerves that provide that sensation. People with a complete loss of sense of smell can typically still kind of sense volatile things like ammonia that you mentioned. A lot of people tell me they can smell gas when they're pumping it if they spill a little bit. And the reason for that is because you also have pain fibers within your nose. And so those get triggered at high concentrations of kind of volatile odors like ammonia or gasoline. And even alcohol can do that. And so you can perceive that something's there. It's frequently hard to identify, but it's not necessarily true olfaction that you're detecting. It's not true smells. It's actually triggering pain fibers, but it's usually present even in people who've completely lost their true sense of smell.
So there's not a lot of research, or I'm not aware of a lot of research, when it comes to ears and nose with PCD. A lot of it seems to be directed to the lungs. So can you speak about research that's being done or treatment?
Yeah, absolutely. I think this is a really exciting time for PCD research within the ears and nose. So exactly as you had mentioned, there's very little kind of data that exists about optimal treatments for the ears, optimal treatments for the nose, and really what the effects kind of long-term are of the ears and nose and the diseases associated with those. So we're hoping to be funded for a grant through the through the GDMCC that'll have essentially one major project aimed at looking at the ears and nasal manifestations of PCD. It'll be conducted over 5 years, and the first part of the grant will be to kind of really understand what the sinus disease is that patients with PCD experience. We know that they have smaller sinuses than average. We know that the sense of smell is decreased, but we don't know whether there's any kind of genetic correlation with the disease, and we don't really know whether that is something that occurs slowly over life with multiple infections, or whether it's something that people are born with. And we're hoping to get to some of those answers, as well as kind of what makes the mucus different in primary ciliary dyskinesia compared to other types of sinusitis. I think, as most patients with PCD know, when you blow your nose, the mucus is really tenacious. It's stringy, it's hard to get out, and it's really frustrating for patients. And there's a significant difference in the mucus, and that's another component of this grant, is trying to understand what those differences are and whether there'd be any better treatments than just using saline rinses to help improve the quality of life and overall health. From an ear standpoint, the other component of kind of this ear and nose grant is going to be understanding the hearing loss that's associated with it. There's some decent studies that show that probably 90% of kids under the age of 5 have bilateral fluid in their ears, and that can result in a pretty significant hearing loss. But we don't really know what happens to that over time. It seems to get better, but it's definitely present in lots of adult patients that I see. And so we're trying to kind of better define the types of hearing loss, whether it's just a hearing loss from the fluid, or whether there's kind of nerve injury causing a sense of neural hearing loss that occurs over time, and trying to really understand what the pathophysiology is of the ear disease and sinonasal disease in primary ciliary dyskinesia. So I think it's an exciting time for this type of research. It'll be being conducted at 4 centers in North America, and we'll be looking to recruit 100 patients with primary ciliary dyskinesia over the age of 5 for this study.
I'm here with Dr. Heymut Omran from Germany, right?
That's right.
And he may look a little familiar. I had the opportunity to interview him at ATS, but he was a speaker here at the PCD Foundation conference. And so one of our patient questions was, how many genes have been identified so far for PCD?
The primary ciliary dyskinesia is actually a term that we use for a group of disorders. So there are many different disorders that are actually summarized with this kind of term. And we now know more than 40 genes that actually cause primary ciliary dyskinesia. Actually, about half of those genes cause a PCD, a primary ciliary dyskinesia type, with laterality defects. So half of the patients have either situs inversus or heterotaxia or a normal composition of the heart. But other genetic defects, for example, they actually cause, for example, a higher rate of hydrocephalus, or some of the genetic defects can cause, in addition to respiratory disease, male infertility. So depending on the genetic defect, the clinical phenotype, so the clinical picture of the patient, is different. So I think this is really important to remember.
Okay, so let me just ask you this question, because we've always heard that usually men with PCD have a harder time with, having children, where it's impossible. So are you saying that there's actually, it depends on the gene?
Exactly.
Okay.
I think about it depends really on the gene, and about half of the males might actually be fertile. So it really depends what kind of genetic defect you have. And there's only limited amount of data published, but we know, for example, that cytoplasmic pre-assembly defects are very often associated with male infertility. On the other side, we know that some specific radial spoke mutations are not associated with male infertility. So it really depends on what kind of disease you have.
All right, great. I mean, this is, 20 years ago we didn't have these genetics, and it's just amazing how it's just exploded. And to me, what we're learning about PCD, and even the differences. We talk about how variable PCD is, but yeah, I'm excited to learn more as we get more on the genetics of how that presents differently with each of us patients.
Yeah, actually there's also some data that some clinical pictures, so some diseases caused by specific mutations, some of those individuals have a more severe clinical cause concerning respiratory phenotype, or they have a more subtle clinical cause. So, but this is something that we are actually investigating and we try to learn, and therefore it is really important that patients actually participate in registries.
Well, that's it for this edition of My PCD Life. And my next video, I had the chance to sit down with the very busy Michelle Mannion. So I appreciate her time, and she will be the next video that I post.